Good afternoon, students. Today in this video, let us see about peripheral acting analgesics. In the previous video, we had seen about central acting analgesics. Here, let us see the information about peripherally acting analgesics. So, these peripherally acting analgesics are also called as opioidal, non-opioidal analgesics or non-narcotic analgesics. These NSAIDs can be abbreviated as non-steroidal anti-inflammatory agents. So here the word steroids you may be heard because these steroids are best anti-inflammatory agents. They show action either by causing immune suppression or by blocking the secondary mediators which will be get released from the inflammatory packets. The secondary mediators which include prostaglandins, phytoxytryptamine, or leukotrienes. So they may be get blocked, thereby they show anti-inflammatory responses. In the similar way, there are some chemicals, so they show same anti-inflammatory responses similar to the steroids, but chemically they are not steroidal in nature. So those class of agents are called as non-steroidal anti-inflammatory agents. Let us see about the drug classification of NSAIDs. So these NSAIDs can be classified based on the mechanism of action. In the coming slide, I will be talking about mode of action. As I told, inflammation may happen because of the secondary mediators released from the packets. These secondary mediators include prostaglandins, phytoxytryptamines, and leukotrienes. So now, if you see about the biosynthesis of these prostaglandins in the inflammatory packets, the major role of cyclooxygenases can be observed because the synthesis of these mediators will happen with the influence of this cyclooxygenase, where whenever rupture happens to the membrane, a tissue rupture will release some phospholipids by act of an enzyme called as phospholipases A. Arachidonic acid will be get produced from the phospholipids generated from the cell membrane. So this arachidonic acid will undergo two pathways like cyclooxygenase pathways and lipoxygenase pathways. In the cyclooxygenase, the prostaglandins will be get synthesized, which are the major inflammatory mediators which causes redness, swelling and pain, whereas lipoxygenases, leukotrienes will be get released. So now the major mechanism behind peripheral acting analgesic, that is the inhibition of prostaglandin synthesis via arachidonic acid with the influence of an enzyme called as cyclooxygenase. So now many of the drugs, they are going to block this cyclooxygenase enzyme. So these cyclooxygenase enzyme are of two types, COX-1, COX-1 as well as cyclooxygenase 2. This cyclooxygenase 1, so they have some physiological housekeeping mechanism also, like the prostaglandin synthesized from cyclooxygenase 1 may protect the gastrointestinal system which got secreted in the gut, whereas other physiological responses also they possess, especially tissue building mechanism they have, whereas cyclooxygenase 2 mediated prostaglandins, they have some pathological role, like they mediate inflammation as well as the pain. So now the target, it should be blocking cyclooxygenase 2 mediated mechanism of prostaglandin synthesis, whereby we can achieve control over the inflammation as well as the pain. Let us see the classification. We have both selective as well as non-selective here. The first class of agent is non-selective cyclooxygenase inhibitor. So they are also called as conventional NSAIDs. So these class of agents, they don't distinguish cyclooxygenase 1 as well as cyclooxygenase 2. Much of the things they are irreversible also. Example is aspirin, phenylbutazone, indomethacin, brufen, mefenamic acid and diclofenac. They are non-selective. They can block both cyclooxygenase 1 as well as cyclooxygenase 2. Blocking of cyclooxygenase 1 may lead some of the side effects. In the coming slides we will be talking about that. Now we have second class of agent, that's the peripheral cyclooxygenase 2 inhibitors. So they are preferential towards the cyclooxygenase 2. They give more priority to the cyclooxygenase 2, but even they have a chance of blocking cyclooxygenase 1, but preferential COX-2 inhibitors there. Example is nimesulide and meloxicam. And the third agent we have, that is the selective COX-2 inhibitors. They are very much choosy. They block only cyclooxygenase 2. Example is celecoxib, rifacoxib, valdecoxib. And we have a fourth class of agent, that's analgesic antipyretic with poor anti-inflammatory action. So these class of agents, they have milder responses. Example include paracetamol and metamazole. Let us see about some of the adverse effects of NSAIDs. As I was told about the cyclooxygenase pathway, where I have told the inhibition of cyclooxygenase 1 may cause some of the side effects. So they share toxicity due to prostaglandin synthesis inhibition. As I told, this prostaglandin is having some housekeeping responses. They can protect the gastric mucosa. Upon blocking cyclooxygenase 1 mediated prostaglandin synthesis, there may be chances of gastric mucosal damage, peptic ulcers can be observed, bleeding can be seen in many instances because they have a property to block platelet function also. Inhibition of platelet function can be observed, especially aspirin in the lower doses they have this, thereby bleeding can be observed. Even limitation of renal blood flow can be observed, so thereby renal damage can be observed. Even they can delay or prolongation of labor can be observed by using cyclooxygenase. That's why before labor these drugs should be stopped. Even they are much contraindicated in the asthma patient and also in anaphylactic reaction. So even some of the beneficial effects we can come across blocking the prostaglandin synthesis. In the previous slide we had seen the drawbacks of prostaglandin inhibition. So now let us see about the benefits. What are the advantages of blocking this prostaglandin synthesis inhibition? The primary advantage, that is the analgesia can be observed because they can prevent the pain because of the nerve end sensitization. So thereby complete analgesia can be observed. Even additional advantages, this agent possesses antipyresis response which can be used in fever. Even it's also having antithrombic responses. Even it can be used in closure of ductus arteriosus in newborn. It's the best anti-inflammatory responses where the swelling in the inflammatory packets can be reduced. It can also be used in menstrual pain, that is a dysmenorrhea condition, and also having antiplatelet aggregation property which can be used as antiplatelet agents. Let us take an example of NSAID, that is aspirin, and let us try to understand the pharmacological action of aspirin. Remaining all the drugs under the classification will be compared with the aspirin in order to study the pharmacology of the agent. Let us start with the aspirin. The first primary action of aspirin is analgesic, antipyretic and anti-inflammatory action. Let us compare this analgesic response of this aspirin with the other class of agent what we have discussed in the previous class, that is the central acting analgesics. When compared to the central acting analgesic morphine, this aspirin is weaker in response towards the analgesic action, but additional it can relieve the inflammatory pain, there's any tissue injury pain which cannot be addressed with the morphine. They are not effective in visceral as well as the ischemic type of pain. It's not having any sedative action. Other advantages like it can raise the pain threshold. One more advantage, it's not having any tolerance and no physical dependence can be observed, whereas morphine had this side effect. So even it can relieve the signs of inflammation like pain, tenderness, vasodilatation, leukocyte infiltration, all will get suppressed. Let us see about the other action of this aspirin, like metabolic effect. So they have significant only in the anti-inflammatory doses. because those doses will be get varied. Anti-inflammatory doses usually it will be high. In such condition only metabolic effects can be observed, where cellular metabolism will be raised in the skeletal muscles. So it can be observed because of uncoupling of the oxidative phosphorylation. Overall, the net effect we can see increase in the heat production and also glucose utilization can be observed. This is the effect on the metabolic. During metabolic effects, we can observe decrease in the blood glucose level. Thereby, it is contraindicated with the people who is with the diabetes, because already he will be under oral hypoglycemic or insulin treatment. If he is taking NSAIDs, so there may be chances of decrease in the blood glucose level, so thereby synergetic response can be observed. Care should be taken. Even it can decrease liver glycogen level, and even hyperglycemia can be observed in the toxic doses. So this may happen because of the sympathetic stimulation which will be observed upon administration of aspirin in the anti-inflammatory doses. But chronic usage may causes negative nitrogen balance, and also it increases carbohydrate and protein and decreases plasma free fatty acid and cholesterol level. These are the metabolic effect of aspirin. Let us see about the action of aspirin in the respiration. So here dose dependent responses they shows us, like anti-inflammatory dose, it causes respiratory stimulation. So this respiratory stimulation may happen by peripheral or central mechanism. Peripheral mechanism because of increase in the carbon dioxide, because already we have seen about the metabolic changes. Increase in carbon dioxide may causes respiratory stimulation. Even centrally also they increases carbon dioxide sensitivity, so thereby they causes stimulation of the respiratory center. The net effect we can observe like hyperventilation can be seen, especially hyperventilation can be noticed in the salicylate poisoning, but simultaneously we can observe respiratory failure, so thereby death can be observed in the toxic doses, because all the stimulatory responses may end with the depression. The next response is on the acid base and electrolyte balance. Here usual dose 0.3 to 1 gram. It won't show much effect, but anti-inflammatory doses will be higher, as I told, like 3 to 5 gram per day. So sufficient effects can be seen, changes in the acid base and electrolyte balance can be observed in the anti-inflammatory doses. So initially respiratory stimulation which was observed in the previous slide, it causes hyperventilation, where much of the carbon dioxide will be washed off from the body. So thereby it will lead to a condition called as respiratory alkalosis, because acidic value or pH will be get dropped. It will turn towards the alkaline. Respiration is the reason for this hyperventilation. Thereby respiratory alkalosis can be seen. Still higher doses causes respiratory depression. Because of this carbon dioxide retention can be seen and respiratory acidosis can be observed. So initially respiratory alkalosis was seen. So further, because of respiratory depression, carbon dioxide retention can be observed and respiratory acidosis can be observed. And also it causes metabolic acidosis, because anaerobic condition metabolism will happen, either glycolysis, because more carbon dioxide can be absorbed because of respiratory depression. Thereby accumulation of lactic acid, pyruvic acid and acetoacetic acid can be seen, and even metabolic derived sulfuric acid, phosphoric acid can be seen, because there will be inhibition of the renal blood circulation, especially in the poisoning condition. In such condition we can come across with metabolic acidosis. Simultaneously we can see increase in the water loss in the urine, sweating and also in hyperventilation. So this may causes metabolic acidosis. This effect on metabolism. So in the next slide let us see about the effect on cardiovascular system.